Esperemos 2 minuticos. Yo creo que ya. Ahí ya me oyen, sí. Bueno, buenos días para todos. Aquí seguimos con nuestros webinar precongreso de la Sociedad Latinoamericana de Citopatología y de Azocolpat. Sean todos bienvenidos. Esperamos que ustedes y sus familias se encuentren bien y que sigamos con el entusiasmo para nuestro congreso. Hoy tenemos una invitada muy querida, la doctora Erika Rodríguez. La doctora Erika nació en Brasil, en el estado de Sergipe. Ella se graduó de patología en la Universidad de Sao Paulo y de patología clínica en la Universidad de Johns Hopkins en Baltimore, Estados Unidos. La doctora Erika además es fellow en patología oncológica del Camargo Medical Center de Sao Paulo, fellow en citopatología de la Universidad de Pittsburgh y en patología de la Universidad de Pensilvania. Actualmente se desempeña como citopatóloga en el hospital de la Universidad de Johns Hopkins en Baltimore. La doctora Erika acaba de escribir un libro, un excelente libro, se llama Atlas de Citopatología y el modo del libro es un acercamiento diagnóstico basado en los patrones. Es un excelente atlas, es muy lindo, ayuda mucho para el acercamiento diagnóstico tanto en la ginecológica como en la no ginecológica. Muy bueno. Y Erika además es una persona muy alegre, muy contenta, llena de buena voluntad y siempre queriendo apoyarnos. Ella también está invitada al Congreso y quiso enseñarnos de citopatología ginecológica mostrándonos estos casos. Muchísimas gracias, Erika, muy querida y bienvenida.
Thank you, Esperanza, for your kind words. It's such a pleasure to be talking to the Spanish audience that is so close to my heart. My Z is, Rodriguez in Portuguese is with S, but my husband is, his family is from Dominican Republic, and that is why I have a Z in my name. And I am learning Spanish. I'm improving my Spanish, and I hope next time I'll be able to give this talk in Spanish. But today we are going to be talking about the PAP test, some interesting cases that we've seen in the recent, 6 months or so. So this patient is our first case is a 66 years old female with a postmenopausal bleeding, no history of abnormal PAPs on our system, and she's multiparous. And now let me show you the slides. Oh, wrong case. So basically on the smear, although she is 66 years old, I guess even from this power, I am at 20x, we see that she has a lot of superficial cells. Here we use SurePath, which is one of these, liquid-based preparation. I know that most of the people use thin prep, but we use SurePath. So we start to see a lot of glandular epithelium and a lot of maturation for a 66 years old woman. And keep in mind that she has a history of bleeding, and when the bleeding in this patient group is very concerned, because she should be already menopause and now she is bleeding. And then we don't have any history of abnormal PAP. So when I'm looking at this, and I am already thinking that she must have something abnormal. And here we see some glandular cells, right? It's slightly three-dimensional. The cytoplasm is slightly vacuolated. There is an abnormal nucleus. And if you think about her age, we are always thinking about, oh, this is probably of endometrial origin, those cells, although they do not have that tight look of normal endometrial cells seen in younger women. And then we keep looking at some of the cells. Seems to me like they have a very prominent nucleoli. It is a little bit more challenging. They almost look it's on the same plane. But again, it's kind of difficult to tell which exactly these cells are. But the nucleoli is giving me signals that I should move and look more carefully for this type of glandular epithelium. And here we start to see more of those. And here, and something that I pay a lot of attention, here is that we have a, prominent nucleoli. The distribution of the chromatin is irregular, so there is this chunk of chromatin and then this opening space, and you can see in most of those cells. Another thing that I like to point is the enlargement of of these cells. I think they're endometrial. They are very three-dimensional. The position of the nucleus is at the periphery. The architecture is getting complex. It's not that tight little ball that we usually see in endometrials in women over 45, but the ones that you call just older EM45, endometrial cells in women 45 years old or above. This is very atypical to me, and I am reaching the point that I am start consider cancer. Even why I'm considering not quite there yet, because of the classic appearance of the we do not have diathesis. Could this be a very reactive looking endometrial polyp or endocervical polyp? Well, they don't actually look very endocervical to me, and the endocervical sometimes they can get very ugly, but remember that the cytoplasm will be a little denser, and here we are seeing a very the cells are very enlarged and the nucleus is abnormal. And she has endometrial bleeding. So basically, my thoughts in here, and I go ahead and look at the squamous, they are definitely, I think I favor those being endometrials. They are endometrial, very three-dimensional. They are very atypical. They are enlarged. We remember that endometrials, the size of the nucleus should be the size of the nucleus of intermediate cells or the size of a red blood cell, and it's much larger than that. So here is a question of threshold. We have some clusters very atypical. The chromatin is irregular, there is overlapping, there is enlargement, the necrosis is missing. To make this call very easy, and then I look at the imaging and see that she has endometrial thickening. So to me, putting these together, and I'm just going to see if I can find places that I dot. Putting these together, I call this case, and this is a recent case, endometrial carcinoma. I call adenocarcinoma. And again, there is no necrosis, and I feel like you can argue against that and say, I like to see necrosis, and I think it's reasonable. So when we are talking about endometrial cells, what we expect to see is that tight group of cells with the nucleus is irregular at the periphery and no atypical, no major enlargement. When they start to get atypical, the definition is nuclear enlargement. When we compare with the normal endometrial cells of the patient or the size of the intermediate cells or a red blood cell. And when we think about adenocarcinoma and what we are going to see, actually depend on the type of adenocarcinoma and the differentiation. But the cells, they are going to form these tight groups of hyperchromatic cells. The nuclei is going to show pleomorphism, loss of polarity. The cytoplasm is vacuolated. The nucleoli, it varies. It can be small to prominent. In our case, it was very prominent. And this we already repeat. So basically, we call these adenocarcinoma, but I think it's very reasonable to call atypical glandular cells favor neoplastic. And here is our surgical pathology follow-up. Oh. So basically, she had a total hysterectomy, and as you can see, it's the same cells that we are seeing, these very prominent nucleoli. So we are happy that this correlated well, but again, I would not object if you think that it should have been called atypical glandular cells favor neoplastic, because the majority of the cases you are going to see necrosis. The thin, liquid base sometimes wash it a little bit, the necrosis, and becomes more difficult to see, but it is one helpful criteria. So the surgical pathology follow-up was serous carcinoma, and had all these stains confirming. And this takes to another case, is that this case came the same week, and both were 66 years old with no history of abnormal path. And thankfully, sometimes similar cases, they come together. And this is a different story. We have a very atrophic atrophic smear loaded with cells that from this power we already see as glandular and neoplastic. And again, it has a very prominent nucleoli. This time we can see necrosis, even singly. I like to see the necrosis coming out of the atypical clusters like we see here, the clinging necrosis. And I just want to call your attention of the prominence of the nucleoli in the enlargement, in the architecture, in the amount of neoplastic material or atypical cells. Things that I do pay attention is the architecture of the clusters. When I start to see endometrial cells or glandular cells that is irregular, is not forming that tight little ball, I start to think that this could be neoplastic. Of course, this case is so it's so abnormal that we would not have problems with that. But I guess there are a few challenging things in this case. First is a patient with atrophy. Atrophy sometimes is difficult to tell if it's indeed necrosis or apoptotic debris, cellular debris, due to the fragility of the epithelium of the on a woman, on a postmenopausal woman. And the other thing is, in some areas, it looks like, could that be endocervical? Because in some areas, it looks like there are some cytoplasm at the periphery. And we have the age that help to guide us. But the truth is, when it's invasive and the patient does not have a history, we usually here at Hopkins, we do not call endometrial adenocarcinoma. It's because of the treatment, right? The morphology, when it gets into invasive, it overlaps a lot. So if you already have a history of a woman having ACG and AIS, meaning endocervicals, atypical endocervicals, or that would guide us a little better. But a woman without a history, she is more into the history of having endometrial adenocarcinoma. But it's better to take a tissue so she can be, guided for the neoplasia she had. This woman, she was actually HPV positive. But we do not have her slides on the follow-up. Her follow-up was also a serous carcinoma. So we signed this as, I put this together, sorry, for us to discuss a little bit endocervical adenocarcinoma versus endometrial. As we know, there is a lot of diathesis. Sometimes when we can see strips, rosettes, and feathering, especially when it is EIS, but the rest is very similar. Sometimes we can see the neutrophils on the cytoplasm. But again, in a poorly differentiated any adenocarcinoma, you can see those. So it depends on your comfort level, what your clinicians require from you. But again, the morphological features are most in keeping with endometrials, adenocarcinoma. But usually here, we prefer to use the nomenclature adenocarcinoma. So we interpret the PAP as adenocarcinoma, and the surgical pathology was also a serous. This patient just had a biopsy, so she basically was treated with a chemoradiation without a surgical specimen. And I guess that is one of the reasons we don't say endocervical versus endometrial when we are not when the patient does not have some sort of history because of the treatment. We have our case number 3 is a 60 years old female, also with postmenopausal bleeding and no PAP on our system. She is multiparous also. And as you can see, we have a theme of 56 years old woman. So this patient, we see that she has, a lot of intermediate cells. And from this power, I am still on 20X, and we start to see cells that looks kind of glandular, right? The nucleus, it's vacuolated, the nucleus is very irregular. It seems like in some areas we have a prominent nucleoli. And keep moving, we see we definitely already reach, we have some sort of lesional, right, tissue. And here is a little difficult to see. It's three-dimensional, but it's not. The cytoplasm seems a little bit denser, and the nuclear is very wrinkled, has a very high nuclear to cytoplasmic ratio. And then we have to keep looking because I still cannot figure out what this is. And then we see some cells that are more pycnotic with a high nuclear to cytoplasmic ratio, but they are lesional. And if I would bet, I think those are more in keeping with maybe squamous. And but this is more glandular and three-dimensional. And we know that every time that you have atypical squamous and atypical glandular, some sort of high-grade squamous lesion going up in the canal, statistically, but that is difficult to wrap our mind around. She is old, but we have some, and I do pay a lot of attention on single cells. I'm one of those who goes and hunt for the single cells, because sometimes in this darker cluster you cannot see very well. And then on this darker, you can perfectly see that this is the cytoplasm is very squamoid. But in other areas is it looks more glandular. I would say that even in some areas, it looks like it's going to endocervical epithelium. And then we have some atrophic epithelium. So I think we can go on and on. And but at some point, and I signed this case too, I think I start to see these dark clusters. And with these cells that I was convinced that was malignant. Let me show a little bit more. And it's always an adventure to sign a PAP malignant these days, because we are having very little malignant case, thankfully. But we are having single cells that look squamous. And I think even some of the cluster seems to have a little bit of keratinization. Here are some more. And so how I interpret this PAP, and retrospectively, it was wrong. I mean, not too wrong, but to me, sometimes as long as you call something that is going to take action, it's okay. So basically, we have a population of abnormal cells. I think this was one of the clusters who helped me to solve the diagnosis. And I thought that was a little bit perhaps of necrosis, some single cells. We see a lot of those single cells with a high nuclear to cytoplasmic ratio. That is a good pattern for at least HCO. I thought this case had too much atypia, and I'm not sure if showing the right clusters, but these clusters are very atypical. It's kind of difficult to see, but they look more squamous by the base of the cytoplasm, although there is a vacuolization. So it's kind of difficult to tell. And we see a lot of these are very abnormal cells. So let's see, there is one extra dot that I didn't show. This is what the first one. Yeah, so basically it's very abnormal arrangement, very three-dimensional. So this case, it's very interesting because when I pull this case, I didn't agree with my interpretation. But looking carefully, and I probably spent a lot of time with this case, and this a lot of dark. So possible interpretations for this case. I think anything that you call adenocarcinoma, atypical favor neoplastic, and atypical squamous, I think is a valid thing. I just call adenocarcinoma. I didn't, to me, once you call malignant, and I think the majority it looks adeno, but this was actually called as adenosquamous carcinoma, and the biopsy was on the endometrial. So basically, it's an endometrial adenosquamous. Retrospectively, I saw the squamous epithelium, those small cells that we are seeing, they are squamous, and probably I should have made a comment on them. But I guess to me, at that day, I got into adenocarcinoma was enough. Let's look at the surgical pathology correlation, and here we have we can see some of the squamous and some of the glandular component. Not an interesting area, I think. And so very clear-cut diagnosis. This woman, her P16 HPV, this is a HPV-ish, these little dots, and they were positive. So she was positive for HPV-16 on the ish. That was a very interesting case for me because I didn't see the squamous component, and I think the lesson for me is I should have called something high grade for the squamous ASC or ASC-H or even HCU. I think it would be appropriate. But I actually don't remember many cases that I have called adenocarcinoma, especially in a woman of this age, and HCU. So I guess that was the lesson for me. Never forget this. Never forget your possible second diagnosis, even if you reach the first diagnosis very easily. Our next case is a 50 years old woman. She has no previous history. And let's take a look at her pap. And again, a very atrophic. And we know how this atrophic smears can be challenged because the nuclear enlargement and all the atrophy, all the atypia of maturity being clearly benign. And here we have some cells that have a very high nuclear to cytoplasmic ratio, and they kind of stand out on her background. And one of the difficulties in PAPs of an older woman is to identify, is this necrosis, or this is the glandular debris that we see on those patients. Seems like maybe there are some cells in here, but we cannot see very well. So what I like to do is to get into these small little clusters. And every time that we have these dark clusters, I go and hunt for the little cells, because in those I feel like you can see better the nuclear details. And with that, I think I'm comfortable to say this is I am at least Ask HCL. Why? When we have the patients with atrophy, we have all these parabasal, basal cells. The cells are small, and the nuclear to cytoplasmic ratio is already elevated, but the nuclear membranes are round. And you usually have the entire population with looking more or less the same, but these populations of cells, they stand up. They have a higher nuclear to cytoplasmic ratio, but the nucleus is not round anymore, and the nuclear contours are more irregular. There is irregular distribution of the chromatin. So if I find more of those, I am getting very satisfied. And we get again on the problem is going up in the canal or not. The cells look very atypical, and we see a lot of those debris. So again, could that be, is this true necrosis or not, is always a question. So the type of cluster that I like to see to make the call, I'm not seeing keratinization to tell, I think this is real necrosis or not, is when I see a cluster and the debris are in between the cells, and the cells are kind of falling apart. So they are not forming that hyperchromatic tight group. Everything is like falling apart. So that is where I like to see the necrosis in these cases. When you have the differential, is it necrosis or is the cellular debris that we see in older patients? To be honest, my threshold is higher, because we know how difficult it is, and it take me a while to get convinced that they are indeed necrosis. I look to see in several fields atypical cells, markedly atypical cells, and type of these grungy debris. And then at some point, I got convinced that this was the real thing. As you can see here, this is necrosis, very atypical cells. And then I received the result. I checked the HPV result in another area that the cluster, this is very atypical with the clusters falling apart. So, and then I checked the HPV result. It was available for her, and the HPV, high risk HPV was negative. So, but again, we know that a small number of patients have a HPV negative squamous cell carcinoma. And also we know that the test can have, it has a small probability, but can have a false negative rate. So this case we did call, so let's discuss a little bit about atrophy. So we know that in atrophy, the cells can exfoliate, forming this hyperchromated crowded group that is very difficult to see. But how is the benign atrophic squamous epithelium looks like? They have the cells around, they have a dense cytoplasm in larger nuclei, which is 2 or 3 times the size of a normal intermediate cells, with a high nuclear to cytoplasmic ratio. But the majority of the population has round, uniform nuclei. It's enlarged, but they are uniform and round. So when we see dysplasia on atrophic smears, and that is something that I repeat always when I'm signing out, is that it just looks like HCO. You have to look at the cells, and they look HCO. They are usually small cells with a high nuclear to cytoplasmic ratio and very irregular nuclear membranes. If you see cells that are enlarged with enlarged nuclei, they are not your classic HCO, so I will be more careful calling in atrophic smear. Some people call this ASCH. I think I came in peace in calling them ASCO sometimes when we see these very gigantic cells. And the majority of the time I call them negative, and we haven't been, having a good follow-up. If we have a rounded nuclear membrane and the cells is enlarged as an older woman, it's probably, okay. If you don't feel comfortable, I think ASCOS is fine. But if you have the same nuclear features that you see in HCU, in a woman of reproductive age, it is HCU. How the DESA system does not divide into keratinized and non-keratinized, but here just for didactics purpose, we have to remember that the non-keratinizing squamous cell carcinoma, they present sometimes as this hyperchromatic crowded group. They have sometimes prominent nucleoli that it would help us also, because HCU does not have prominent nucleoli unless it's HCU growing to the glands, and then it's the gland that has a prominent nucleoli. So it should not have a prominent nucleoli. And then non-keratinized squamous cell will have irregular chromatin distribution. I always like to look into that whitish versus dark spaces on the nucleus. So the nuclear feature sometimes on the non-keratinizing is similar to HCU, like we saw in our cases. But if you see tumor diastasis and you are convinced this is tumor diastasis, and we are showing here a little quicker for interest of time, but we go very diligent in looking in these clusters, and we are very strict on what is tumor diastasis if we are going to make this type of calls in atrophic in a definitive call. So we interpret this one as squamous cell carcinoma. I think other options would be called HCU cannot exclude invasion, or even HCU. I think it could be appropriate depending on your threshold. The PAP, we know we don't render a diagnosis like the clinicians would like, but it's an interpretation. And the problem, in some people, I've heard some people that do not give the diagnosis of squamous cell carcinoma because you give the license to chemoradiate without tissue. And I understand that concern is reasonable. And but I think to say that at least you cannot exclude invasion, it's important. We do call. I try to have convincing diathesis to call. squamous cell carcinoma. In the case of this case, that the patient was HPV negative, I sweat a little longer to give this diagnosis and even to define how far to go. And I think it was fine. She had just a biopsy that we are going to show, and she was treated only with that. And she had, it was invasive. I hope I pulled the right slide. That has some areas of invasion. And as you can see, it's not very keratinizing. So that is a lesson. Sometimes we can encounter HPV negative squamous cell carcinoma. It's rare, but if you put the combination is HPV negative and an older woman, add a little bit of complication to our life. So the case number 5 is 64 years old woman with a history of gastric type mucinous endocervical adenocarcinoma and treatment for that. And we are going to show her BAP. And again, she is very atrophic. And even on the first field, we start to see these cells that are very large, and the nucleus is large as well. And I always like to look at these cases very carefully, because I think it's how, we get trained to identify these reactive changes. So she has a history of gastric type adenocarcinoma of the cervix. We see some cells that are vacuolated, but they are multiple. They have multiple vacuoles. The chromatin is hypochromatic, and that is something I pay a lot of attention. That it's very rare to have like the hypochromatic type of HCl, and it's not possible that everything is going to show up on your sign out. It's so basically that's what I'm looking for. So the patient had a history of endocervical adeno, so I'm looking for adeno. If I have doubts, I pull the previous specimen and hopefully will be available for review. This woman did not have anything available for us to review, but the cells are very enlarged and have vacuoles. So we look at those very carefully, and they are keeping with the hypochromatic theme of the nuclei. Let's see if I have something uglier than that. So when we are talking about this entity, and we do have some cells that are, atypical, but they are vacuolated. There are some like polychromasia on the cytoplasm. I believe it's a little harder to see through the screen. But I think we are ready to make our call of just negative cytology. And we do. And of course, if you do not feel comfortable by any means, you can always call ASCOs. Of course, the clinicians don't like that. But the truth is, there is some radiation changes. That's what we like to call. And then again, if you're seeing you can have this grungy material, necrosis or necrotic-like material, but nothing that looks like her previous tumor. So for us, we accept that, and we are going to discuss a little bit more of the chemoradiation changes. So basically in chemoradiation, the major characteristic of that is cytomegaly. So both the cytoplasm and the nuclear are enlarged with a near normal nuclear to cytoplasmic ratio. The cells are usually can be like 30% or greater of the pre-treatment cells. The cytoplasm, one of the characteristics is vacuolization, polychromasia, vacuoles that can be seen on the cytoplasm and on the nucleus, multinucleation, wrinkling of the nuclear membranes, and bizarre shaped cells. So that takes us to case number 5. So we interpret this case as negative, no intraepithelial lesion cancer identified, and reactive changes consistent with a treatment effect. And as this woman did not have a follow-up, but she's alive and all her PAPs have been negative, and she was HPV negative. That takes us to our case number 6, which is a 76 years old woman with a history of squamous cell carcinoma. And then, so she has a history of squamous cell carcinoma. We know that she received chemoradiation. And then we have like 2 nightmares, right? There's a patient with an atrophic background, 76 years old, with radiation changes and with a history of cervical cancer. So it doesn't get better than that. And then we start to look at, she has a lot of maturation for 76, right? Some red, some intermediate, some pinkish. And we start to look around, already thinking this is going to be too much. And we look around. And we start to see some, cells that are big. The nuclear to cytoplasm ratio may be fine, but they are very hyperchromatic. When you compare with the previous case that we just showed, the cells were like hypochromatic. And then we see some smaller cells. And again, when I am overwhelmed by this amount of ugly cells, I go and look for cells I can recognize. And then when I'm in peace with them, I go and extrapolate the thoughts for the other cells. So basically, in this setting, I want to rule out, I am very concerned already that this woman may have a high-grade lesion. It's kind of difficult to differentiate between, is this atypia treatment effect or not. And I go and start to see some squamous that are smaller. And we're looking in here, remember that the cells with radiation changes are enlarged. And we start to see the small cells, right, with very regular nuclear membranes, very high nuclear to cytoplasmic ratio. They don't seem to have, this one has probably some radiation changes, but these seem fine. It's just the same cells you see in HCU. So I'm going to look for more of those that I can get convinced what they are. And then we see some clusters that is kind of keratinized. and seems like to have a very atypical nuclear features. But I don't see necrosis. And we keep moving because there are lots of changes that is difficult to tell what it is. This one looks like could be radiation, could be glycogenation of the cells. She's an older patient, but this is enlarged. So, who knows for sure? But there are some that I can't tell. And I go and look for more of those. I think the money is on these small cells where we can see the nuclear details a little better. This is kind of, there is something that I am very concerned, and there always is how far to go. And don't think that these diagnoses come easy. It's very easy to put all these difficult cases together and just walk through. But we look at very carefully. And again, my favorite and what you should be looking for is what you can call HCO. And there is no treatment effect in here. There is no nucleomegaly or cytomegaly. The cells have a high nuclear to cytoplasmic ratio, irregular membranes, irregular distribution of the chromatin. So to me, I am ready to call at least a sketch. And then I will look at, carefully and we see this bothers me. It has radiation effect, but remember that, atypical cells or even neoplastic cells can show radiation change. And then you have a tadpole, but we learned on the previous slide that they can have, but the nuclear is not as hypochromatic. And look at the distribution of the chromatin. So I'm very concerned, but what sells to me is the the smaller cells with a high nuclear to cytoplasmic ratio, where I can, say, okay, I am convinced if I have these cells in another woman, in a woman without a history of radiation, I can call this HCO. And I think at some point, I got that. Clusters of cells that has the same characteristic features that you see. Now, are those the big cells here? They bother me because they they are different from the previous case, for instance, that we saw. Here are some other of these very typical cells. And here we see that they have a high nuclear to cytoplasmic ratio. It's not that I am ignoring those larger cells with a very hypochromatic group. I do think they are not just radiation change. I think this is, is lesional, is probably high-grade lesion or above. But my definitive call depends on me seeing the small cells that I like for HCO. And I think here is another cluster that we can agree that is HCO. So in dysplasia, few things that I look in these cases if the patient has symptoms. Usually these patients with a lesion after chemoradiation, they will have vaginal bleeding. The cells have a high nuclear to cytoplasmic ratio. You can have the large atypical cells with increased nuclear to cytoplasmic ratio or small cells. Usually you have a mixture of those. I like the small cells just because it's easier. And I just think, okay, what I would do with this HCU in a patient without chemo radiation. So if you're thinking about squamous cell carcinoma, compare with the previous specimen. I think this is a very important step because the cells that are there most of the time, they will have the same characteristic of the previous tumor because they were not touched by the chemo. That's why they are there, although you can have with tumor changes. But I like to think that is the same, that if I see a cell and I ask myself, would I call this cancer in another setting? So it's the same. The diagnostic criteria is the same. So, and this study is a very nice study from Mexico that actually they look at 80 and some cases of patients with biopsy-proven HCU with radiation changes. And they found that a lot of the patients had actually hemorrhagic background, but those were conventional smears. We know that the liquid base kind of clear the hemorrhagic background. The abnormal cells are ranging groups of syncytia. They have increased nucleus and increased nucleocytoplasmic ratio, irregular membrane. And if you have hypochromasia, you can diagnose as HCU. So we interpret this one as HCU. And we had her biopsy also show HCU with radiation changes. And this is her biopsy. And as you can see here, all those larger cells are here. So this thing about, is the largest cell is not HC on radiation. It's not true. If it's hyperchromatic and it starts to get a lot, I would be very careful and look around very, very carefully for those small cells that you can call HC. I think worth the hunt. Or HC, or at least ask H. I think to me it's very difficult to call a squamous cell if I do not have the previous biopsy. And it's important to know that when you have squamous cell carcinoma post-radiation, something that is helpful to know is that the majority of the patients has disseminated disease, the majority of them. So that could help you push you one way or the other, or perhaps just say suspicious if the patient doesn't have, metastatic disease, or, how far you go. I am guided a lot on these cases by the clinical history, by the majority of the cases, but especially on these, challenging cases. And as you can see here, let me show the P16 on this case. And it's basically loaded with a P16. Even the largest cells that we would think, could they be reactive? Look at the P16 on them. Alrighty, and then we are reaching our last case that is actually very interesting too. So this is 57, and the patient has a history of LEEP for HCU. Okay, let me just go back to. And again, another atrophic. Because I'm sure you guys see a lot of young women with lesions, and I find the most difficult PAPs are the pregnant woman and the older woman. And so this is a woman that has already a history of HCU in the lip, and we are just moving around, and even on the first field, I see cells with a high nucleocytoplasmic ratio, irregular nuclei. So with these two cells, I am already concerned because this is not what you should see on reactive changes or atrophy alone. And to me, it's the same thing. I would ask myself, if this was a young woman, would I call something on those two cells? I would. And then we keep moving, and we see some cells that are more of what would you expect on an atrophy, this enlarged but round nuclear membranes, and you start to see there are some cells that are just beyond that. And what triggers to me is to look for my little small cells that I can put in another woman and say, okay, would I call this in another woman? And then you go, because this is just the changes of atrophy, but then you have these type of cells here and there. And to me, those are like the most important diagnostic clue. You have a population of cells that stand up. If it doesn't stand up, look for it very carefully. Not the round cells, but when you start to see all, oops, that was the highest already. All the nuclear membrane irregularities and the high nuclear to cytoplasmic ratio. So although we have a lot of cells that are in the spectrum of what we would see, some are not. And, depend on your threshold. I think we call this one HCl. But I guess if you call ASK-H, would be okay too. Depends on how your clinician sees. So, and this, as you can see, there is a lot of keratinization that I didn't mark too much, the keratinization, because I was and those are more on the same case. I just skip these dots. We have some of those and these very ugly cells in some keratinization. I just want to show those to you, and some very ugly enlarged cells. So we call this case HCl. Okay, despite of this keratinization and ugly cells. And so basically, the so-called keratinizing HCl usually will have a little bit more than what we have today, but I think this is a decent example. The cells have, you see classic HCl plus a population of cells identical to keratinizing squamous cells. They usually lack prominent nucleoli and necrosis. A little caveat is when the HCl doesn't have usually prominent nucleoli, but if it's going to up in the canal into the glands, you can see nucleoli. And then there, they can have little apoptosis and may look like necrosis. So to me, if I'm going to make this call, the necrosis has to be convinced, it has to be in several fields. Otherwise, I will go suspicious or cannot exclude invasion, how is said on the list. So in keratinizing HCC, I guess the major difference is the abundant population of keratinizing cells. Some people say if you have 75% of your abnormal cells keratinizing, you should call keratinizing squamous cell carcinoma. Usually you can see prominent nucleoli in diathesis and broken down blood elements. So interpret as HCO. This was a vaginal pap. And they sign as fragments of at least high grade. Let's take a quick look at the biopsy. Oops. And here is the biopsy, the same cells that we were seeing on the pap. So I guess that's all I have for today, and thank you so much for sharing your time with me. It was a real pleasure to put this case together.
Thank you very much, Erica. I am going to ask for questions. Okay. Quisiera saber si hay preguntas al respecto de cualquier caso o comentarios en general. I would like to highlight the important paper of cytology in endometrial cytology. And I would like to ask you, can you give us a clue, the most important clues to differentiate between endocervical and endometrial cells, dysplastic or no plastic? Thank you.
Yes, so basically the endocervical and endometrial, I think is, we like to say that endometrius, the nuclear is at the periphery, they form like a berry, and endocervical, you are going to have the cytoplasmic tail at the periphery. Some people say that the endocervical adenocarcinoma, you are going to have more on the on your smear than the endometrial adenocarcinoma, and I think it depends on it. Honestly, we've seen lately so many endometrial adenocarcinoma. And they are, as we show in one of the examples, they are loaded with endometrial groups and endometrial cells. And sometimes I feel like if it's a high-grade tumor, it will be, you have a lot of endometrials there. So I don't think this is a good criteria. But in the endocervical, if you have like strips of cells that is a AIS still, and you have that acina formation, I do believe it overlaps. And if it's an older woman, we can always be guided by the history, by the age. But the truth is, and we have these a lot in here, that if you give a diagnosis, perhaps the patient will go immediately for treatment, and it's important to differentiate endometrial from endocervical. And morphologically, we have clues of that, but at the end, you may not be able to differentiate them. And I think we needed to respect the limitations of the method, because when we do not respect, we make mistakes, and it's very costly, right, for the patient. So it's better to be, to hedge a little bit if you cannot tell. If it is forming three-dimensional balls, I do not call endocervical, even if it's a youngish woman. For me to call endocervical, adenocarcinoma endocervical, no adenocarcinoma inside, but adenocarcinoma endocervical, it needs to have at least like a good background of AIS that I can see for sure it is. I have to feel very confident, convinced, because of the the importance of the call. We never know when the patient is going to treatment without biopsy. So I think that's a difference nowadays, that we are invited to be more conservative.
Okay, thank you. I want to highlight also that in our media, that with the new devices for the sample cytology, we have to be very attentive to know more about glandular cells, because we are
Yes.
going to see more of them, isn't it?
Yes, I agree. And I think we are just, finish a study on a comparison in our lab. Our number of PAPs have reduced with the changing guidelines, but our number of diagnosis of glandular lesion has been increasing in the late few years, in 2 3 years. It has a significance. I had 1 week that I signed 2 or 3 that I thought there was endometrial adenocarcinoma, and that is a lot. um, so, and if you ask me how many squamous cell carcinoma I sign per year, I may sign 1 or 2 squamous cells. So I think that endometrial carcinomas are increasing, and we are going to miss those with the change on the guidelines if we go forward with everybody doing the HPV test only. But I guess on the sidelines is the majority of the patients with endometrial lesion, and that's a good guidance, is they have bleeding, vaginal bleeding. So I think it's important to know. But again, if it's a youngish patient, define abnormal vaginal bleeding sometimes can be difficult. So if it's a postmenopausal woman, it's easier, and you say, oh, that is bleeding, perhaps should not, go to the guidelines with HPV only. But I agree that is increasing, and that we may not be able to diagnose them because the path, the change on the guidelines.
Thank you very much. Quisiera saber si hay comentarios o preguntas. La doctora está muy abierta a cualquier... aquí veo una pregunta del doctor Matute. There is a question about what do you think about the microglandular hyperplasia as a differential diagnosis in endocervical lesions?
Yes, those are, those are pitfalls that are terrible for us. We are lucky that they are rare, but again, is that's why sometimes we like, or most people like, to see necrosis. The few cases that I've seen did not have necrosis. So, and I think the quantity also is something that helps me. If I don't have necrosis, if I have a lot, it pushes me to a more definitive diagnosis. But I don't see a problem of if you have little, called atypical glandular favor endometrial or atypical glandular favor neoplasm. Again, usually is going to cost the woman just a curettage. To me, the major mistake is calling adenocarcinoma and coming back, a polyp. That is like a nightmare. But if you just push to have a tissue diagnosis in these borderline cases, I am in favor in being conservative and not being, a hero in 5 cells and make a big call and hurt the patient. So.
Okay, thank you. And no hay más preguntas o comentarios. I want to highlight that if when we have a case with elements of squamous and glandular, is better to focus on squamous?
I usually focus on squamous. Depending on the age of the patient, I
Okay.
usually focus on squamous, yes. That is why I always look for the squamous, and that where I get convinced. And then you go, oh, is it going to the glands? Because if you think about, we all have this fear that is going to be a HC plus AIS, but the majority of the cases is HCs involving glands. So to me, to call AIS, HC plus AIS, I have to be very convinced of the AIS part. It has to be a predominant, and I may call even atypical glandular if it's something borderline. Um, but because the majority is just HCU involving endocervicals.
Okay, thank you very much. There are many people that we are happy to see that many people from Latin America, Mexico, Peru, from many cities from Colombia are connected. So we are very grateful to you, Erica, and we are going to learn about a lot about your cases. Very interesting and very illustrative cases. No sé si hay algún comentario más antes de despedir a la doctora. Pues quisiera que estuvieran libres de hacer cualquier comentario o pregunta para ella antes de despedirla. Entonces, si no hay más, nos vamos a despedir agradeciéndoles a todos el apoyo y la asistencia. Erica, thank you very much. Thank you very much. Really very interesting cases. Thank you for your time. And we hope to count with you in the future also. Okay?
Sí, muchas gracias, Esperanza. Mucho gusto estar con usted. Y la próxima vez yo voy a hablar en español. Gracias.
Ok. Muchas gracias. Muchísimas gracias. Muchas gracias y a todos gracias por la asistencia. Buena tarde.
Buenas tardes. Bye.
Okay. Goodbye. Thank you.
Thank you.